behalf of the Blood Disorder Administration and the Ministry of Health, it's my great honor and privilege to warmly welcome you to the 4th edition of the Inherited Blood Disorder Summit 2026. On the way out, the organizing group, the organizers will guide you to the dinner hall. And thank you so much. See you tomorrow, sharp at 9. Distinguished guests, esteemed colleagues, partners, and dear friends, on behalf of the Blood Disorder Administration and the Ministry of Health, it's my great honor and privilege to warmly welcome you to the 4th edition of the Inherited Blood Disorder Summit 2026. On the way out, the organizing group, the organizers will guide you to the dinner hall. And thank you so much. See you tomorrow, sharp at 9. Distinguished guests, esteemed colleagues, partners, and dear friends, on behalf of the Blood Disorder Administration and the Ministry of Health, it's my great honor and privilege to warmly welcome you to the 4th edition of the Inherited Blood Disorder Summit 2026.
on the way out, the organizing group, the organizers will guide you to the dinner hall. And thank you so much. See you tomorrow, sharp at 9.
Assalamu alaikum wa rahmatullahi wa barakatuh. Distinguished guests, esteemed colleagues, partners, and dear friends, on behalf of the Blood Disorder Administration and the Ministry of Health, it's my great honor and privilege to warmly welcome you to the 4th edition of the Inherited Blood Disorder Summit 2026. Assalamu alaikum wa rahmatullahi wa barakatuh. Distinguished guests, esteemed colleagues, partners, and dear friends, on behalf of the Blood Disorder Administration and the Ministry of Health, it's my great honor and privilege to warmly welcome you to the 4th edition of the Inherited Blood Disorder Summit 2026. Assalamu alaikum wa rahmatullahi wa barakatuh. Distinguished guests, esteemed colleagues, partners, and dear friends, on behalf of the Blood Disorder Administration and the Ministry of Health, it's my great honor and privilege to warmly welcome you to the 4th edition of the Inherited Blood Disorder Summit 2026.
On the way out, the organizing group, the organizers will guide you to the dinner hall. And thank you so much. See you tomorrow, sharp at 9.
خليها شوي. خلي الميوزك عادي كده 2-3 minutes. ممكن أحد يبعت اليوتيوب لينك نرسله في الجروبات. يوتيوب لينك. أيوه حق اليوم اليوتيوب لينك. أحتاجه أنا عشان I forward it. أوكي. Good morning, everyone. I know it's Friday, so probably the crowd wouldn't be enough before Friday prayer, but I'm sure that afternoon will be much people there. We have a YouTube link, so people are watching those presentations from their home. So I want to pass this message to the presenters and moderators because we're still active and people are watching us and learning a lot from us. We say in Arabic, Jum'ah Mubarakah, so blessed Friday, because it's a very special day for us. So today is Jum'ah, inshallah, and there will be Jum'ah prayer. We will show the agenda shortly, but I want to show you what happened yesterday, and it's just, we're looking forward to 2 very busy days. So if you could put the video up, please. Distinguished guests, esteemed colleagues, partners, and dear friends, on behalf of the Blood Disorder Administration and the Ministry of Health, it's my great honor and privilege to warmly welcome you to the 4th edition of the Inherited Blood Disorder Summit 2026.
On the way out, the organizing group, the organizers will guide you to the dinner hall. And thank you so much. See you tomorrow, sharp at 9.
I'm sorry, it's already 9:30, but I wanted people to be here at 9. So thank you so much for making the time. So the agenda is really busy today. We will have the official opening ceremony with the Vice Minister, inshallah. And what's different this time
that we're doing something different, and hopefully we're leaving an impact, where we have lots of esteemed experts from all over the world, but we have two important organizations with us, the World Federation of Hemophilia and the Thalassemia International Federation. And I'm happy to announce, and I'm honored that we're signing MOUs with them today. So it will be fun to watch how we sign MOUs at MOH. The other thing is, before I go to the agenda, lots of activation stations outside, but I want to just bring your attention to a very important hall. It's called the Blood Disorder Administration Hall. So there are few things there that please, I want you to go and look for them and see how could you give us your fingerprint to make an impact. The whole summit is designed with the idea of what does fingerprint mean, but fingerprint merged with blood drop to make it healthy, but at the same time, given the new era, it's digitalized now and we're into the AI technology. The BDA hall has few things. So we have the hologram of our great team that works behind the scene. Everyone is saying their role in the administration, but through a storytelling, which I really like and enjoy. And then we have our projects that we're working on. So you have the ushers there to guide you. How could you learn more about the projects that the ministry is doing, specifically for blood disorders? But last but not least, we can't do anything with our patients. So I want to bring your attention to a station there. It looks exactly the same summit theme. When you there are headphones, put the headphone on, put your fingerprint, and you have 20 patients talking to you. They're telling their stories. Those are our patients that are enrolled already in the 90 days program of Mohja, and these are our ambassadors to move this project for well-being moving forward, inshallah. So enjoy the day. Let's go through the agenda quickly. We have lots of sessions, very busy as you could see. Inshallah, we will have the Friday prayers. Transportations will be available to take people who are interested to the mosque. And we will come back for lunch, and then we will have the official opening ceremony, signing the MOUs, an important announcement that the BDA is doing today as well. I wouldn't tell you, so I'll leave it as a surprise. And I'm sure that you will be happy and sharing the experience. And then we will finish the day. Tonight, we have our gala dinner in a lovely place in Riyadh. We're going to a small hall where we will enjoy dinner and some Saudi theme. Worth to mention that the Saudi founding day is in 2 weeks. So it will be Ramadan, so we will not be able to celebrate. So we are celebrating it today. So it will be the Saudi founding day. And there are outside photo booth where you could select a scene from Saudi and take your photo with the scene of your choice. I think I did the housekeeping, so dinner is important. There will be transportation and guidance for you through the day. Our team and Smart Health team is out there to help you. Very quickly, I have 3 esteemed moderators in the first session, and it's my honor to present them to you. So the first session will be Professor Salam Al-Kindi, who's our dear friend from Oman. And I think he's well known to everyone, but he's the director of Hematology and Bone Marrow Transplant Center, the professor and a senior consultant department of Hematology at Sultan Qaboos Muscat Oman University. Following his graduation from Trinity College in Dublin in 1993. You shouldn't be mentioning years, yeah, Dr. Salam, Allah yahdik. No years, huh? No ages. I have completed my general medicine, or he had completed his general medicine as well as hematology, oncology training in Dublin, Ireland, and Fred Hutchison Cancer Center in Seattle. So you were my neighbor to some extent. where he did his training in bone marrow transplant in 1999. He had joined Sultan Qaboos University, and in 2005, he was appointed as the head of the Department of Hematology for 10 years. Previously, he held many positions. One of them is the Deputy Director of Sultan Qaboos University Hospital for Clinical Affairs for 5 years. Research interest is a lot, but it includes sickle cell disease, chronic leukemia, myeloproliferative disorder, with over than 150 articles published. Quite impressive career, mashallah. So Dr. Salam will be our moderator, first moderator. My dear friend Dr. Inshirah, who always come very fast when she's called on, although I don't do the opposite, so I do apologize in front of everyone. Dr. Inshirah is a consultant adult hematologist at King Fahd Hospital, Medina, where she serves as the head of the adult hematology department and distinguished institutional official. She completed her fellowship in adult hematology at King Abdulaziz Medical City and holds the Saudi Board in Internal Medicine. Dr. Bernawi has held several regional and national leadership roles, including hematology supervisor for our Medina region and a member of the Saudi Hematology Advisory Committee, with a strong focus on clinical care, education, health system leadership. Last but not least, I am honored to present a person that we work closely with at the ministry, and I'm really privileged to know this guy who's very enthusiastic and active and managing the blood bank systems at MOH and in Saudi. Dr. Ali Al-Jouhi is an executive healthcare leader and clinical biochemist, currently serving as the executive general manager of blood banks services at the Ministry of Health. He holds a PhD in clinical biochemistry from Manchester Metropolitan University, and he has over than 20 years of experience in laboratory medicine, blood bank operations, quality management, and national regulatory framework. Dr. Al-Jouhi has led major national initiatives in laboratory transformation, plasma fractionation, accreditation, and workforce development across Saudi Arabia. I would like to welcome you all, and let's kick off the day. Professor Kindi.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Hatoun, for this generous introduction and for the invitation, and welcome everybody on this Friday morning. I'm Salam Al-Kindi, and it's a pleasure to introduce the first speaker of the day, Dr. Irfan. They sent me another biography, so I'll stick to this one. He's a clinical hematologist at the Amsterdam UMC and program director of stem cell transplant. He earned his PhD and MD at the University of Amsterdam and completed training in internal medicine and clinical hematology at Amsterdam UMC and Sanquin research. His work focuses on sickle cell disease, stem cell transplant, and gene therapy, and he's actively participating in clinical trials, etc., in Europe and beyond. It's my pleasure to introduce him to come and talk on curative and modifying therapies in sickle cell disease. Welcome, Dr. Noor, and the floor is yours.
Assalamu alaikum, good morning. Thank you very much, Professor Al-Kindi, for the generous introduction. So it's my pleasure, thanks to the organizers, to be here. I was asked to talk about curative and disease-modifying therapies. I will talk about disease-modifying therapies only slightly and go on to curative therapies. So I would like to first start by introducing the pathophysiology. You might know that, but I think it's good for the context of this talk to go through that. So it's actually I will stick to sickle cell disease mainly, not so much thalassemia. So sickle cell disease starts with a point mutation in the beta globin gene, and which leads to the hemoglobin getting into the sickle hemoglobin, which then polymerizes, and that causes the elongated sickle cell form of the red blood cell, which then goes on to hemolysis, intravascular hemolysis. And the release of these molecules, hemoglobin, heme, and iron, leads to oxidative stress and inflammation. And then that goes on by activating the endothelial cells. The integrins will be activated, complement is activated, and then there is, at the end, there is vaso-occlusion and ischemia. And then there's also reperfusion, which also causes oxidative stress. So this is a very vicious circle of pathophysiological factors, and you can, every step of this pathophysiology can be a target for therapies. So we have the hemoglobin F inducers. Main of them is hydroxyurea, which has been an established treatment for many years. So then you target the sickling, which is relatively stream upwards. And another potential treatment is the anti-sickling compounds, which have been introduced recently with mixed success, because voxelotor was taken off the market, but successive drugs are probably coming. And then we have pyruvate kinase receptor activator, which is also pyruvate kinase activity is also reduced in sickle cell disease. So by activating this receptor, you increase the energy of the red blood cells actually, and also it reduces sickling. And then you go stream downwards, and then you can give antioxidants. As I told, it's a disease of chronic oxidative stress, but there was a clinical trial that showed some benefit with L-glutamine, but I think it's not, at the end of it, it's pretty stream downwards. And then you can also apply a complement inhibitor to limit the circle of endothelial activation and hemolysis and vaso-occlusion. Studies in mice are very encouraging, but in human beings it still needs to be seen. And then further stream downwards, you can block the selectins, anti-selectins, and we all saw that crizanlizumab, which is a p-selective inhibitor, seemed not to be working in a large phase 3 clinical trial. And then we can go stream upwards to the main problem, which is the mutation. We can fix that by either by stem cell transplantation or hopefully by gene therapy. And that's what I will talk about in the remaining of my talk. So the first patient who was cured from sickle cell disease was this lady in the United States and St. Jude's, who had acute myeloid leukemia at the age of 8 years in 1983, and she was treated for the leukemia and then transplanted, and she was cured from both the sickle cell disease and acute myeloid leukemia. And since then, the numbers of transplant patients have been increasing with each year. These are data until 2017, but the numbers have increased only further since then. So this is a large registry study of 1,000 patients who are transplanted with matched sibling donors. You can see that the survival is actually very good. The red curve are the patients who have received bone marrow transplantation with overall survival of above 95%. So if you look into this, these are data reported to ABMT until recently, and you see that most of the transplants are in children, but also the numbers in adults have been increasing, and you can see that most transplants are myeloablative, busulfan based, also trisulfan based is a large group, and But if you see the number, there are some small, apologies, there are some small numbers of adults being treated with myeloablative treatment. And if you look into this curve, which is very good, but if you look into the different ages, young and 16 years or older, then you will see that the survival in the older patients is not that good, with overall survival and event-free survival of around 80% in the patients with 16 years or older. And most of these patients, majority of these patients, had received myeloablative conditioning regimens. That means mostly busulfan, which is very toxic for adult patients. This is another study, registry study, also showing the same trend, that young patients are doing very well with myeloablative regimens, but the older patients, 6 to 14, are doing slightly less well, and the patients of 15 years or older are doing even worse, with an overall survival of 88%, which is actually not acceptable for a chronic disease which is not acutely dangerous for the patients. And probably this increased toxicity, increased mortality in sickle cell patients is due to this accelerated organ dysfunction, accelerated organ aging, especially of the vital organs such as heart, lungs, and the kidneys, which are associated with increased mortality in sickle cell patients, but also in transplant setting. So we know that allogeneic stem cell transplantation is an established curative therapy for sickle cell children, but there are two main problems that had to be addressed. First is that there is significant toxicity, as I showed in the last slides, with the myeloablative conditioning regimen, especially in the adults. And the second one was that the results of the matched sibling donor transplantation are very good, but not everybody has a matched sibling donor, so there was a need for alternative donors. So first, the need for non-myeloablative regimen. This is the first, one of the first successful regimens that was developed by the NIH in the United States, using alemtuzumab, which is an anti-lymphocyte antibody, in combination with low dose of total body irradiation of 3 gray, and these patients received unmanipulated peripheral blood hematopoietic stem cells, followed by sirolimus as a GVHD prophylaxis. The first results of studies, including a study from here from the United States, from Saudi Arabia and the United States, the group of Dr. Al-Zahrani, and these patients were first 122 patients did relatively well. They typically had mixed chimerism. For those of you who are not in the transplant field, mixed chimerism means that they had a part of their own blood cells and a part from the donor. There was graft failure in around 13%, and interestingly, 20 to 30% of the patients had to use sirolimus as for a long term because of a risk of secondary graft failure, and so that was also a problem. So why is the risk of graft rejection increased in sickle cell disease, just as in thalassemia? That's probably because of the expanded bone marrow. Because of the very active hematopoiesis, the bone marrow is expanded. There is an increased oxidative stress, increased inflammation, chronic inflammation, and these are factors which are not very friendly for the newly arrived stem cells of the donor. And in contrast to the patient that I showed you who was treated for AML, these patients have not received pre-treatment, so that also might play a role. So now we have a delicate balance between the toxicity of the myeloablative regimens, which also kills patients, and the risk of graft rejection if we give too light conditioning regimens. So how can we improve the outcomes in transplantation without risking too much toxicity? So we in Amsterdam, at Amsterdam UMC, came up with this modification. We thought if we add this preconditioning with azathioprine hydroxyurea for 3 months prior to the condition which was developed at NIH, we might tackle these two problems of expanded bone marrow and the chronic inflammation with azathioprine and hydroxyurea. And these are our results of the first 25 patients, and since then the numbers have only improved, and we see actually a very good event-free and overall survival of 96%. We had only one patient who had graft failure, who also didn't have autologous regeneration and died due to infections, but the other patients are engrafted and doing very well. And these are our chimerism numbers. So in red you see the myeloid chimerism, which is representative of the red blood cells, that's hovering around between 90 and 100%. And in blue you see the T cell chimerism, which is important to be majority donor derived in order to defend your graft. And you can see that T cell chimerism in our patient is increasing about 50% around 1 year, and then goes on to higher percentages. And this is very important if we compare with the study that I showed you before with the patients from the US and Saudi Arabia, then you see that the T cell chimerism is around 50%, and some of the patients had lower than 50%. So you have here that only 68% of the patients were able to stop sirolimus at 2 years. So 1/3 of the patients had to still use sirolimus because they were at imminent risk of secondary rejection. And so I think we have tackled this problem by achieving much higher T cell chimerism in our patients, which enabled us to stop sirolimus in all of our patients. So stopping the sirolimus in our patient population was 100%. So then there is the second problem is the lack of HLA identical sibling donors. How to tackle that? Finding match unrelated donor is not very easy, and the first results of the first studies were also not very encouraging. So the focus has been on haploidentical donors. Then you will have almost a very large pool of donor, because you can use children, brother, sister, half brother, half sister, nephew, nieces. So that is makes it an unlimited pool of donor. And these are the results of a global consortium which we were also part of. You can see here the results of both adults and children who received this reduced intensity regimen with quite extensive with ATG, thiotepa, fludarabine cyclophosphamide, low dose of TBI, and then post-transplant cyclophosphamide. You can see that event-free survival and event was graft failure or death was very high, around 95% in the adults, but lower in the pediatric patients. So this is the first study that shows better outcomes in adults than in children. But if you look into overall survival, that was fortunately comparable between both of them, because there were 8 patients who had graft rejection, but all of them survived and had autologous regeneration. So the overall survival is still good in both groups. And so what about, so we see these beautiful curves, they survive, but what do the patients say? Are they happy with this treatment? So we investigated this with prospectively with a mixed method. So we did a qualitative interview, and we also did quantitative evaluation with PROMISE. This is patient reported outcome measurement information system, and here you can see the physical health of patients. So if you are in the red area, then it's poor, it's worse than the average population. The dot line in the middle is average Dutch and Belgian population. So here you see pain interference. Patients had pain, as you can expect, and that improved 6 months after transplant and improved further, completely coming to the green area. So patients scored better than the general population. And then you have physical function. is very poor in the red area, and that increased to green area, which was statistically significant. Sleep disturbance improved, but it slightly improved only slightly. And this was very funny because these patients were sleeping, they had sleep disturbance, which is known from sickle cell disease, but later on they complained of sleeplessness because they had too much energy. They had a lot of, had very high increased hemoglobin. And fatigue also improved significantly. And then mental health, which is anxiety, anger, and depression, all of them improved. But here you can appreciate that it didn't improve within the first year, and that's because we keep these patients coming to the hospital every week, and we keep them to a lifestyle regimen. So as soon as they are done with us at around 1 year, then they come less often to the hospital, then they score much better. And then social health, also very important. The ability to participate in social life and their satisfaction with this social life was also improved significantly after the transplant. So then what about gene therapy, gene editing as a one-time treatment option? So you can call it curative, but some call it one-time treatment option. Before I go into the therapies, it's good to just to shortly discuss the some historic perspective, which has been very short, which is short history. The pace of developments have been it has been breathtaking, and it probably all started with a clinical vision after physicians saw that patients with sickle cell disease or transfusion-dependent thalassemia who also had hereditary persistence of fetal hemoglobin, they did relatively well. So that then the vision of reprogramming of red blood cells to reactivate hemoglobin F came to life. So then research by the group of Stuart Orkin and others looked into the genetic background of this hereditary persistence of hemoglobin F, and they found out that there was a gene B11A in chromosome 2, which was associated with higher HbF production, and then they using genetic manipulation, they saw that deletions of this B11A led to complete normalization of hemolysis because of increase in HbF in sickle cell mice. And then further on, using CRISPR-Cas9, they found out that B11A is the repressor gene for gamma globin, which leads to the switch from HbF to HbA. And then further research found that a specific area within this B11A, this red area, was the erythroid specific region, which was important for the activity of B11A gene and erythroid cells. So it's a B11A erythroid region is erythroid specific. So just shortly also, so you have the fetal stage of hemoglobin F. You have this activator transcription factor that sits on this box in front of the gamma globin. So you have a locus control region on gamma globin. So this is expressed, and the beta globin is not expressed. So in the adult stage of erythroid cells, the B11A comes to this box instead of the promoter area and kicks out the activator of gamma globin, and then pushes the locus control region to the beta globin. So gamma globin is switched off and the beta globin is switched on. But there, of course, is the problem that we have this mutation of sickle cell. So here we have this machinery of the gamma globin genes, which have been switched off by the B11A. We have the locus control region on the beta globin, but here we have this sickle cell mutation. So how can we change this? We can either disrupt the BCL11A, we can disrupt or modify the promoter regions, so then we have HbF induction, so that's one option. Or maybe if we are successful, we can correct the point mutation, and then we can, by both ways, we can probably kind of cure the disease. So if we do the disruption, we have HbF, and we have, if we have the correction, we have will have HbA. And we use these gene editing strategies. I will show them here. So for gene editing, I'm focusing on gene editing, not on gene addition. For the first approach that is also currently used by Vertex is that of inducing double-strand break. So you break both strands, and then you can either leave it to the cellular machinery to fix it, and the cellular machinery will use non-homologous end joining, so they will just stitch the ends together, and that's error prone. So that means it's not, it will not repair it as it should be, and that's something that's okay for disrupting a gene, for example, for disrupting BCL11A. So it's not very elegant, it's not very specific. And then you can also do homology-directed repair, so then that's more precise. But for that, you will have to provide a donor DNA template so that that can be put into that double-strand break. So first, let's focus on this one, which is used by Vertex, and you have all, I think, seen these results that it leads to increase in fetal hemoglobin, also total hemoglobin. These are the mean fetal hemoglobin as percentage of total hemoglobin, the percentage of F cells, and here are the number of edited cells in blood and in bone marrow. And these are patients who had a lot of vaso-occlusive events, which cease in almost all patients after they receive this gene editing therapy, preceded, of course, by high-dose busulfan, which is also we shouldn't forget, because it doesn't go without chemotherapy. So this current approach is also with the gene addition indeed does not correct the mutation. We do see disappearance of vaso-occlusive events, and there is transfusion independence in patients with thalassemia, but the HbS is not completely corrected. There is some degree of hemolysis, and there have been some patients who, for example, with Parvo B19 infection, who also had aplastic crisis. So potential long-term complications are still unknown. And what does it mean for chronic organ complications which are related to hemolysis? So this is another approach that was recently used by Editas. So they, instead of targeting the BCL11A, they target the promoter regions. They disrupt this area so that the BCL11 doesn't repress the gamma globin genes. So this also leads to increased HbF, as you can see here. It's a few patients who were treated reaching hemoglobin F levels of 41, 42%. And also these patients didn't have vaso-occlusive events after the treatment. Unfortunately, this product was shelved. I think that's a very strategic decision. Maybe they didn't feel that they could compete with Vertex, which was almost the same results. Then what do we have on the other side? So we have this homology-directed repair, which is more elegant, and with that you can probably fix the mutation. So you can provide a donor DNA, which includes this fixed point mutation, and with that you could cure by correcting the mutation. And there was one patient treated with this approach. Unfortunately, patient remained aplastic for a long time. There were 33% of the alleles were corrected, but this was not very specific, unfortunately, not as specific as they thought. So there was only 12% of HbA, some sickle hemoglobin still, but accidentally they didn't expect this, a very high percentage of HbF, so maybe this is off-target effect. So this patient did improve somehow, but not because of cure, but maybe because of induction of HbF. Also, this company, after this patient, dropped this, and they have now focused on completely different field. So then we have the base editing, which is a newer generation of gene editing. So with these deaminases, you can remove one amino group from a base. So that's also very elegant. So you don't do a double strand cut. You just do only one strand cut and only affect only one base. So we have, there are available, you can convert A to G editor, so then you have the Makassar beta globin, which is abnormal but is not pathological, so that's also an option. But we still don't have A to T converter, which will correct the sickle mutation. But you can also apply this base editing to the promoter regions of the gamma globins, and that's what Beam 101 does. So they edit these promoter areas, and so that's probably more elegant because B7A is also involved in other cellular mechanisms. So if you leave alone B7A and just focus on the promoter is maybe a better option. The first patients who are treated in this study are doing very well. They have a higher HbF percentage than with Vertex, it's 60%. One of the first 6 patients unfortunately died because of busulfan toxicity, so that shows that there is some treatment-related toxicity with this approach also. And then finally we have prime editing, which is maybe the most advanced and hopefully maybe the future of gene editing. It's very complicated, it's a very big machinery that you introduce into the cells with the Cas9, and then also you have the reverse transcriptase in it, and then you have this very big yellow primer editing RNA, guide RNA, and then attached to it is this reverse transcriptase template with it, the edit sequence. So this is something you want to introduce, and then of course the primer binding site, which where the name comes from. So here also we have, you can do a nicking of the DNA, so you cut only one strand. That's better than cutting both of the strands, and then you introduce this target edit sequence. So here you can see that schematically the edit flap is introduced, the unedited is thrown away, and then when it's inserted, and then you still have this non-complementary original strand, which will also be then changed, and then you can fix the disease. And the first experiments are very promising. In ex vivo, so these are hematopoietic stem cells of patients who were edited with prime editing and then introduced to sickle mice, which seem to fix the disease. So hopefully this will be developed further for patients, and if you take it even further, so all of these therapies are ex vivo. The patients have to be treated with busulfan, and then you reinfuse the stem cells. But if we could do this in vivo, that would be of course perfect. Then you have much less toxicity, and there are some developments with nanoparticles to put these constructions into nanoparticles and then introduce them to mice, but in the future hopefully to patients. So in conclusion, outcomes in children with sickle cell disease are of course very good for a long time, but improvements in non-myeloablative regimens have improved outcomes for adults with sickle cell disease. Haploidentical donor transplantation has become a viable treatment, curative treatment for sickle cell patients, and transplantation leads to significant improvement in quality of life, as I showed in clinical observations of hereditary persistence of fetal hemoglobin has led to very fastly to developing gene editing therapies. Now the current treatment focuses on disrupting BCL11A. The beam disrupts the promoter region of the gamma globin, but new developments with base editing and prime editing will hopefully improve gene therapy even further. With that, I would like to thank you for your attention, and again the organizers for inviting me, and I would like to acknowledge our team in Amsterdam UMC. Thank you very much.
Thank you, Dr. Irfan, for your presentation. The question and discussion will be at the end of the session. Thank you, Dr. Hatoun, for the arrangement of the outstanding meeting. And thank you for your invitation and nice introduction. It's my pleasure to present the second speaker for today, one of the famous name from Kuwait, Dr. Hadil Al-Saleh. She's a pediatric consultant in hematology and oncology with a subspecialty training in pediatric thrombosis and hemostasis. She completed her fellowship in Canada, and she holds the Kuwait board in pediatric, and currently she is a practice in NPK Children's Hospital. She's a leader for children and bleeding disorder and hematology malignancy. Dr. Saleh, the floor is yours to present the hemophilia update management.
Assalamu alaikum. Good morning. First of all, thank you, Dr. Hatoun, for your invitation, and thank you for the organizing committee for making this event and giving me the opportunity to be part of it. Today, I'm going to talk about the clinical management innovation in hemophilia. So, as we know that hemophilia is an X-linked bleeding disorder, we have two common types, type A and type B, and the problem is whenever we have those elements in the intrinsic factors, they have like a shortage or deficiency that will induce bleeding for such a case. So the patient will manifest with different type of bleeding, like excessive bleeding or sometimes spontaneous bleeding, sometimes prolonged bleeding can occur with those cases post-op, or easy bruising in some cases, and in some cases they can present with joint and muscle hemorrhage as well. Other cases can present simply with mucocutaneous bleeding like oral or nasal bleeding, or sometimes it could be severe cases with intracranial hemorrhage, like it's common for the neonatal patients with hemophilia. So the history of hemophilia, it's not a new history. It had been started from the 2nd century. It had been mentioned in old Egyptian papyri and also in the Talmud. The Talmudic references had said that if two brothers had died from circumcision, then the third one should be exempted from that. So this is an old history. It's not a new one. Followed by, sorry, there's delay. Followed by the 10th century. Have anyone know who is this guy? Abu al-Qasim. Abu al-Qasim, he is the first Arabian physician who had documented instances of families where a male individual had died due to excessive hemorrhage following minor injuries. So he was the first physician who described the inherited nature of the disease, where he noticed that the males have been affected at the same village after minor traumas or minor surgeries. Also, he was the first to notice that the illness spread within one village and limited to male relatives, indicating the inherited condition for such a case. Also, he had characterized the symptoms for such a case with hemophilia with excessive bleeding after minor injuries, which is the primary symptoms of hemophilia today. His work had been written centuries ago, and he had the one who had provided foundational observation about this bleeding disorder long before, like the modern scientific discovered the factor 8 and factor 9. By the 19th century, I think all of us are familiar with this story, but we skipped the previous one. Like Queen Victoria, like it's a well-known hemophilia B cases, like have been noticed and have been labeled as the royal family disease at that time. Well, Queen Victoria, she passed the gene to 3 of her 9 children, including her son, Leo, the famous one, who have been died at the age of 30 because of repeated excessive bleeding, and 2 of her daughters, where they passed the gene to their grandsons. So one of her daughters have been transmitting the gene to a Russian royal family. Her daughter Alice, where she passed it to her daughter Alexandra, and then to her son Alexei. And also from the Spanish royal family have been distributed the gene also to the families there through the Patricia and through her daughter Victoria, to both her sons Alfonso and Infante. That was the history of hemophilia along the previous centuries. So let us talk about the treatment innovation in hemophilia for the time being. Okay. So talking about innovation, I would like to highlight the WF chapter, where they indicate that, or they recommend a regular long-term prophylaxis as the standard care to prevent hemarthrosis and other spontaneous and breakthrough bleeding, maintain musculoskeletal health, and promote quality of life. As we know, we have 3 grades of hemophilia. We have the mild, moderate, and severe, and it varies with the level of the factors. Like for the mild one, we have 6 to 40%, and moderate like 1 to 5%, and severe less than 1%. And like initiating treatment or standard factor prophylaxis hemophilia severity can reduce those cases from severe to moderate. Like this is the logic or the practical point. But with the new innovation for the treatment, like with the new therapies like the ultra-extended half-life with a rebalancing agent and gene therapy, that raise the bar to reduce and eliminate bleeding even to mild or even sometimes to a normal hemostasis cases. Many papers have been summarizing the innovation over years and years. So let us go through these slides. In 1940s, the usual treatment at that time was to transfuse the whole blood for the patient. Followed by 1960s, the cryoprecipitate was discovered. And the credit was for the Dr. Judith Graham Bull when she noticed called insoluble gelatinous paste at the bottom of previously frozen plasma, which was rich in anti-hemophilia factor. So the cryoprecipitate was started to be transfused at that time, followed by 1970s, where the fresh dried plasma have been started to be used. By 1980s, it had been noticed that the human blood plasma have been contaminated, and the time for like hepatitis and HIV have been spread at that time. By 1992 and 1997, the FDA approved first recombinant for both factor 8 and factor 9, followed by 2000s, where the massive innovation in the treatment, which include the most recent treatment, including like the ultra-extended, the gene therapy, the monoclonal, non-factor therapies have been introduced during that period. So hemophilia and modern medicine have been starting like gradually from 1940s, but have been stopped after the HIV and hepatitis. But after that, the innovation have been running so quickly. Again, if I want to summarize the practice between the old medicine, let's say in 1960s, and compare it to 2020, like in 1960s, the patients, whenever got any attack of bleeding, they need to be admitted, and the option of treatment was limited to FFPs or cryo, and the life expectancy was limited to 20 years or even like around 20s. Compared to the treatment in 2020, the patient can simply take the medication at home by the caregiver, and they will have a normal life expectancy compared to the earlier phase, And the joint disease virtually non-exists in young patients without inhibitors in most of them. So, to understand prophylaxis in hemophilia, like it's a myth condition for a patient who is not on a prophylaxis. So whenever we administered a regular administration of therapeutic product maintaining hemostasis, that will prevent the bleeding and that will keep the cube in a well-organized by the prophylaxis. So what about the innovation in factor therapies? The innovation, as I said, after the phase of 80s, like early 90s and later on, we have like different type of modality for the plasma-derived or sometimes recombinant for such a cases. And I will focus on the standard half-life products and the extended one. If I'm talking about the standard, then we are talking about 3 generations of treatment. We have the first, the second, and the third generation. From the first generation, which was in the early 90s, they used to use the Chinese hamster ovaries or baby hamster kidneys for such a cases. And then it was upgraded in the second generation where they have been using stabilize the product with saccharose in a final formulation, followed by the, followed by the third generation, which is have been used without human or animal proteins. Those are an example for the standard half-life products, and the only message I can endorse it through this slide, it have been typically have a half-life of 8 to 12 hours, and which needs an administration, IV administration 3 to 4 times per week. So that was the standard half-life. What about the extended? What is the difference in the extended half-life? For the extended half-life, actually the bioengineered product have modified the structure by 2 ways, either by bigylation or the FCA fusion. The bigylation will increase the hydrodynamic volume to prevent clearance by kidneys, and the FCA fusion by using the protein region of the immunoglobulin G or albumin to recombinant proteins. And in both ways, they will slow the clearance from body, so that will reduce the time of frequency and time of injection for such a case. For hemophilia A, factor 8, with the extended half-life, the improvement was extended the lifetime like 1.5 time compared to the standard one, and that will keep the frequency of infusion around twice a week instead of 3 to 4 times. But the improvement was greater in factor 9, where the extended half-life have been extended to 4 to 6 times longer, and that will give the frequency to be given every 7 to 14 days, which is like a great achievement by the extended half-life for factor 9 compared to factor 8. So, since nowadays, the gold market, I think everybody is interested, even those who didn't like the gold before, nowadays everybody is interested, and I'm one of them. So let's give the example according to the gold situation. Let's say this is the half-life, and we are talking now about the standard half. So, about the extended factor for factor 8. So the half-life have been extended to 1.5 to 1.6 fold increased. So this is a great achievement. And on the other hand, we reduced the number of infusion to 30 to 35%. If we want to compare it to extended half-life for factor 9, then the half-life have been increased to 3 to 6 fold, and we reduced the number of infusion by 50%. And we also can reach a trough level of 5 to 10. So we will convert the patient to mild form of hemophilia. So this is a great achievement. Again, we are in the gold market. So we have a reduction in the number of infusion, we have a high factor trough levels, and we have decrease of number of bleeds with substantial reduction of the ABR in those cases. So we have a real increase on benefit for the extended half-life, especially for factor 9, sorry. Also one of the innovation for the medication regarding hemophilia A is the Ivanos octacoque alpha Altovio, which have been raised recently for the last 2 years almost. The idea of this factor, the structure had been changed. They did add the BDD factor 8, which is designed to improve stability, and also FC domain have been added to extend the molecular half-life in the bloodstream, and also the extend also have been added to improve the reducing clearance and degradation of the products in the blood, so it will give it longer efficacy and half-life. And also we have the von Willebrand D domain that will allow the molecule to circulate independently to endogenous von Willebrand. So by that product, we can achieve like a great trough level compared to the previous one. So the trough level can reach 40%. So we are almost converting the patient from severe cases to a normal case. So this is a very, for me, an excellent achievement, and I can see it with my patient as well. We are talking about extended, standard, Altovio. All of them have been given or introduced, administered intravenously. Can you imagine if a mother or a caregiver handling like 2 kids or 3 kids affecting with hemophilia? I think this will be a big burden and a big difficult for the mother to take care on scheduling their doses and to search for the vein. I think this is it's not an easy way to proceed, even for the healthcare provider, even for the nurses as well. And sometimes me as a pediatrician, I know the child will escape from the IV line or IV injection. So that will guide us to this slide about the hemostatic system. As we know, we have a balanced hemostatic system. We have the procoagulant and we have the anticoagulant. The procoagulant, we are dealing with factor 8 and 9 and 10 and 2. And if we are talking about the anticoagulant, then we are talking about antithrombin, tissue factor, protein C, and protein S. If we have anything affect or reduce the precoagulant, like factor 8 or factor 9, then the bleeding disorder will appear and the patient will be symptomatic at that time. On the other hand, if we have any defect with the coagulation inhibitors, then the thrombotic events will happen. So in order to avoid anything, we need to balance that scale to ensure there is no bleeding and no clotting. So from there, the non-factor therapy ideas came, where it worked on rebalancing the coagulation cascade rather than replacing the missing factor. So typically administered via subcutaneous region. So we overcome one of the most common challenges by IV administration of such factors. And that will reduce the burden of frequent of IV access for both the patient, caregiver, and the healthcare provider. So the most common one and the famous one is the emicizumab, which is the bispecific antibodies that mimic the cofactor function of factor 8, approved for hemophilia A with and without inhibitors. It can be given once weekly or twice a month or once a month. On the other hand, we have the rebalancing agent that target natural anticoagulation to boost thrombin generation. So it's totally not replacing the factor. We are just playing with the coagulation cascade to balance the hemostasis level for such a case. The most common products we have concizumab, which is a monoclonal antibody that inhibits tissue factor pathway inhibitors, and it can be given daily subcutaneously. We have fitusiran, which is a small interfering RNA, and have been approved in March 2025. Also, it can be given every 2 months subcutaneously, and monthly lab test for the 6 months initially. And we have the last one, the MARSA, and it's weekly subcutaneous with no lab testing needed and can be doubled upon the different cases or personalized cases, let's say. So to understand the previous slides, Well, we have to go back. We have to go back to the coagulation cascade, and we have to focus on this part of the coagulation cascade about 10A and the thrombin. The idea behind the rebalancing agent is to keep the thrombin and to increase the thrombin amount. So, for example, if we are talking about the concizumab, then the effect will be on the tissue factor pathway inhibitors, allowing factor 10A to function better and has shown a high effectiveness in reducing bleeds. If you are talking about servant, then we are talking about protein C and protein S, where it's a modified protease inhibitors that target the ABC. By inhibiting ABC, it preserves the prothrombinase complex and allowing to increase the thrombin generation. And also, if you're talking about fitusiran, then we are talking about the antithrombin, where it works at that side to enhance and to increase the thrombin amount to prevent bleeding for such a case. For all those non-factor, all of them, they have been given subcutaneously, which is like a great achievement. Some of them, they might need monitoring, but for the first imicizumab and the last one, MARTA, it doesn't need. And some of them, we can adjust the dose or we can double the dose, and the washout will last for a long time. Yeah, the washout will last for months for the imicizumab and for the fitusiran, but it will last for days for concizumab and MARSA for a few weeks. Introduction to review series of a new therapeutic for inherited and acquired bleeding condition. There were many papers have been published for that issues. And the most common thing or the most innovation being carried for the hemophilia is the gene therapy. For both factor 8 and factor 9. The gene therapy for hemophilia from basic science to first approval of 1 to done therapies, that paper had been published in 2025. And according to the gene size matters. Like, as we know, the gene size for the factor 9 is much, much easier compared to gene size of factor 8. That's why we have more studies and more review for the gene therapy for factor 9 compared to factor 8. And that had been started from 1997, where there were only preclinical studies in animal, ended up to 2015, where we reached 6 clinical trials in phase 1 and 2. Some of them have been ended to or reach phase 3, and number of patients being included being increasing by time. And this slides will summarize the most studies or gene therapy have been handling by different sponsors and with a different phase of those studies. Compared to gene therapy for hemophilia A, as we said, the gene matters, the gene size matters, and that's why we have like a less compared to gene studies for factor 9, and those also summarizing the most recent sponsored for the gene therapy for factor 8 or hemophilia A. The eligibility for the gene study was limited to adults, those who are 18 and above, and if the case is hemophilia A, so it should be less than 1%, like the severe one, or less than 2% for hemophilia B. One factor prophylaxis prior should be the patient on factor prophylaxis prior to enrollment and willing to discontinue factor after gene therapy. The patient shouldn't have any inhibitors and should not have any history of advanced liver disease like liver fibrosis or active hepatitis, and AVV vector serotype AB negative. The endpoints of such studies change from the baseline to 15 months with the annual bleeding rate, annualized factor 8 and 9 usage, and factor 8 and 9 levels. and the safety, including the infusion-related reaction with a short-term, like ALT and factor levels, and long-term genomic integration, and of course, the quality of life measurement. Though the gene therapy is promising, but still we have some challenges, including the high cost, like it costs millions of dollars per dose or per person, and variable long-term efficacy, like especially for hemophilia A, and potential immune response requiring immune suppression, and patient hesitancy stemming from historical treatment safety issues. So, despite the traumatic advances, are we truly preventing arthropathy, inhibitors, treatment fatigue of hemophilic patient? Does that work? Actually, traditional frequent intravenous clotting factors have been upgraded to a long-acting one, then to the sub-Q non-factor, ended up with the curative gene therapies. These advancements reduce the treatment burden and manage inhibitor, as well as improve the quality of life for patients. So what is new? How innovation is changing clinical decision-making and outcome. As we know, the consequences of hemophilia, more than bleeds, we are dealing with a lifespan from the neonatal period till the elderly time, where the patient have been crossed by physical health and pain management to psychosocial impact, and the stress will start from the newborn, where the risk of ICH is there, and then the risk of inhibitors being doughty for both healthcare provider and the caregiver, and sometimes lack of skills by IV treatment administration will be one of the challenges, and also we need to take care of the family and the caregiver support by the treating physician. It will be our challenge and our work and our homework actually to move on supporting those cases, as well as the lifestyle with independence. Like we know that the parents, whenever they face the first child with hemophilia, that will affect and that will be a big burden on the mother or the father. Sometimes those families will lose their career to take care of their children. So they really need our support in such a case. So the patient-relevant outcomes, I think patients are looking for preventing premature death, improve their quality of life, ability to engage low-risk activities. They want their children to participate, to move on, and it's our job to move them to improve their quality of life and to improve their life activity in both ways, for the affected child and for the non-affected one. The therapeutic innovation in hemophilia, the essential rule of positive reinvestment cycle. This is a very beautiful paper, have been published by Glenn in end of 2025. Actually, he had highlight the hemophilia treatment, evolution and revolution. He focused on 5 categories. The first one about the technology. As I mentioned earlier, from the simple blood transfusion, a cryoprecipitate, factor replacement, then the bioengineering ended up with gene therapy, moving to evaluation of treatment option, like from the replacement by only factors and the blood products to a non-replacement, ended up with the outcome like the ensuring safety of the patient with the 0 bloods and normalization. On the other hand, he did a very well comparison with the cost. Though we have a good innovation, but on the other hand, the cost being increased more and more. It's parallel to the innovation of the treatment criteria. So he did highlight there are 4 main essentials should be considered whenever we are dealing with those cases. We have to look after the sustainable investment cycle, expanding global access, balancing innovation and access, and encouraging market participation. So those are the main essentials that Glenn had focused in his paper, on that paper. So I did highlight the innovation and the option of treatment. Where are we? What should we choose? What the patient would prefer? Would they stuck to the IV? Like, I can convince my parents about the ultra extended half-life. It's amazing. It can push your level from severe one to a normal. So I can make it, صح? On the other hand, for those who are reluctant to IV, I can ask them, okay, what about the sub-Q? We can move on, and it can be given once monthly, once weekly, twice monthly. So we have many ideas and many options. How can we address our thoughts? I think WFH had got the solution. The tool of the shared decision-making tool. This is an amazing tool. Have anybody went through that tool? Yes? Yes. It's amazing. So it's an option that be given to the healthcare provider as well as the patient. So we can share whatever is available in the market, and we can share the idea of how things been moving on with. I reached the end of my slides. Okay. So I will just highlight the most important point on that tool. So there is a welcome notes, like it will introduce about how things going on, and the introduction, like the life goal and what is the treatment preference for the patient with the therapy available, and what is the available information of each therapy that the patient will just click on that. It will give them a brief about those products. And as I said, it's a shared decision making between the healthcare provider and the patient themselves or the caregiver. And the reflection, and the patient can choose what type of hemophilia he is he A or B? And then the reflection, like, we can just reflect on the life goals and the current treatment, learn about the treatment option, as I said earlier, and it will highlight all the newest products which is available in the market. And then there are some questions for the patient. He can answer the questions, so he will reflect his, sometimes they will not express their feeling, but it will be easier if they just endorse it to the tools, and the physician or the healthcare provider can go through that. And the education as well being involved in those categories. Also, there was a scale from 0 to 100, so the patient can score his feeling, let's say, or his management or his progress in the management, and the scale from 0 to 100. 0, it's nothing, 100, it's amazing. And also, this will summarize the tool idea. And there are some questions that we suggested to the patient. He can ask the physician whenever he go to his OBD appointment. Also, we have the mobile health. Away from the treatment innovation, we have also some apps that track the infusion, log bleeds, manage their condition remotely. Also, the point of care ultrasound, that will be a great idea to detect any synovitis earlier to prevent any joint deformity. I will skip this slide because I think I reached my end of my time. So to improve quality of life, we have to ensure preventive treatment and joint health with the pain management, physical activity, mental health, social support, and patient education. By that, we can reach, beyond the bleed, we have a journey for better life. Usually, we ended up our slides with thank you. Actually, we mean by thank you, we are thanking the audience for being patient till the end of the presentation. But I would really endorse my thanks for those who had highlight hemophilia from the beginning, from the Talmud, Old Egyptian, Abul Qasim, all the scientists, Victoria as well, because she distributed the disease all over the world, so otherwise we didn't know about it. And the physicians who have been working on the plasma and the cryoprecipitate as initial therapies, and the scientists who create the extended, standard, ultra-extended, and non-factor therapies, and the gene therapy, which is promising. And a special big thanks for KSAMOH for handling this event and giving us the opportunity to endorse our knowledge and to share our experience in such amazing, wonderful event. Thank you so much.
Thank you, Dr. Hadil, for your wonderful presentation. First of all, I would like to thank Dr. Hatoun Izzat for inviting me to be part of this wonderful event. Thank you so much. It's my pleasure. The third session for today is about clinical protocol in iron deficiency in high-risk population. It's by Professor Farja Al-Qahtani. She is a professor and consultant in hematology and oncology at King Saud University and also King Saud University Medical City with over 20 years of experience. She is specialized in hematological disorder, thrombosis, transfusion medicine, and clinical research. Prof. Al-Qahtani holds advanced degree from Johns Hopkins Bloomberg School of Health Public, and she is completed her research training at Harvard Medical School and served as program director for lymphoma fellowship. So welcome, Prof. Al-Qahtani.
Start. Assalamu alaikum. Dr. Hatoun mentioned earlier, no mention for years, but still he mentioned 20 years of experience. So because of the time, I will be faster in my presentation. I am so pleased to see iron deficiency among other important diseases like hemoglobinopathies and sickle cells, as well as hemophilia, and this is mainly because the high significant prevalence as well among the impact in the health system. This is the roadmap of my presentation. We will try to convince you it's very important, iron deficiency and the burden globally and especially in Saudi Arabia, the protocol initiative, why it's developed, how it's developed. It took from us almost 2 years to develop it in a proper way. And the mechanism of iron metabolism as well, what we mean by high-risk group. WHO responses consider us as the 6th important, and we should achieve the goal in 2023, especially in women age-bearing. This is this year. 2 months ago, in the American Society of Hematology, I saw this big banners, and I sent it for Hatoun just for the initiative of iron deficiency. And if we can remember, in 2018, it was a big banners for sickle cell anemia, and it's written Conquer Sickle Cell. And since then, globally, pharmaceutical are initiative for hemoglobinopathies. And we hope the same for iron deficiency anemia. In this study, they emphasize in the global burden over 10 years on more than 200 plus countries. The lowest, we can see it was in France, and it is in the dark blue. And the highest iron deficiency rate, it is in the red one, and it was in Zimbabwe where the highest red we can see it. Also, we have iron deficiency anemia in Saudi Arabia. A month ago was published from our colleagues in the Saudi Journal, Medical Journal, and this is the largest study, I will consider it, and the figure emphasizing the role of iron deficiency. In this study, they conducted as retrospective. They looked at the result of iron, ferritin level less than 30, if there is CBC or no CBC, and it is the largest study we can see in Saudi Arabia, and they took it among all the cities from Mecca, Riyadh, Hail, and we can see from this slide, the first slide, male and female affected, and whether ferritin is low or they have evidence of hemoglobin. And in the other side, we can see all the city, the darker the red, it's the ferritin low, less than 30. So the conclusion of the study was highlight substantial burden of anemia, iron deficiency among the people or population of Saudi Arabia. It's over reinforced foundation of developing national strategies and managing iron deficiency. What they don't know that Dr. Hatoun 2 years ago started this project as a national project where there is developing a protocol and even emphasize or reinforces among all the MOH. And the importance of this protocol or the iron deficiency to tackle this problem, it has its own impact on the health of the individual, with child aging. It's impaired cognitive motor development in children, increase the risk of preterm labor, low birth weight, even increase in mortality in some of the cases. So there is unmet need for developing iron deficiency protocol, especially in high-risk population. And before we did that, we gathered the team and we tried to study the mechanism of iron metabolism. In order, our protocol will cover all the aspects of iron deficiency, even with what our concern of those who has transferritin or rare genetic disorder like iron refractory iron deficiency anemia, where this is a genetic problem need to be studied. But at least from the history, you can figure out if the patient only respond to iron deficiency to IV medication to give us with normal investigation, that's going to give us a clue this is a patient can be. But we tackle from intake, the intestine, the problem in bone marrow, hemolysis, and from there we started our protocol. We said this is the pathophysiology of iron deficiency anemia. We started from the history. So in our protocol, we try to cover the major history can be taken by the general or the GP in the clinic to see where he can start from his investigation. The other things, there may be patient intake is very well, healthy status, but still he came with iron deficiency, where from there to figure out where we can figure out, is it the blood loss, is there a defect in his observation, medication, H. pylori, achalasia, there must be something to look around. And the symptom of anemia will be details in the protocol. So the second step, who is high-risk population? Is it childbearing age, elderly, children, patient with a chronic illness, heart failure? We can discuss them. And from there, we choose three population, and we started with the most important with elderly as high-risk population. The estimated number, according to the WHO, it will be increasing. So it will be around 12 to 20% of population will be elderly. And they define it as a low as hemoglobin for male, 13 for female, 12. And from there, we started. Why elderly? Because as a nation, majority globally, they are increasing in aging. And with aging, there is comorbidity, chronic illness, and as well malnutrition. Elderly try not to tend to eat well as before. The intake, majority in the clinic patient, elderly 60 and above, they are not taking meat as before. They are full with a lot of polypharmacy to the extent they are not eating very well. They are at risk of malignancy, and they are not aware about that. So they can present it with mild anemia or severe anemia. Their activity is very low. They are at high risk of falls, decrease in activity, extended hospital stay, and even patient with heart failure, patients are given with IV iron, and its effect in mortality, morbidity in those patients. So we developed protocol of anemia in elderly. It was a team effort under the guidance of Dr. Hatoun Azzat, Dr. Salha Misnoura, and we started from the beginning. If patient, what if I am a GB in the clinic, what I should ask from the history, and what's the target to define hemoglobin, the anemia, and what's the initial investigation he need to request from the beginning. CBC, if CBC come, what next? What's the level where trigger to treat or further investigation? And we did this map, like the initial screening. If its ferritin is low, then he needs to go to the step. If it's intake, if it's medication, if he believes there is GI evaluation, if it's severe, where the hematologist needs to step in, or to be admitted and further to have a blood transfusion or more invasive investigation. And we, at the end, if it's simple iron deficiency due to intake, due to GI drugs, then how he need to be treated, and follow up the response of the treatment, and how frequent he need to be. What else advice if he started treatment, he need to inform the patient and the medication, to be aware about the side effect and to follow up. And the treatment we did for oral medication, also for IV medication, and what he need for oral medication to advise the patient to increase the absorption or to get advice to be less side effect from oral medication, and if he not respond, when to start the IV iron. And this is monitoring for the patient, he need to follow up. We put everything could be for the anemia included. This is the final result. طبعا في introduction للpatient, ages, this, the diagnostic management we advise in the protocol to be. It's very detailed, but they need. We try to cover everything, at least to be a reference for the institutions, and they can decide it. Also, Dr. Hatoun suggested that we will make it easy for the general practitioner or the first responder to see the patient, to make it not to miss any red flag signs. So we did pre-order sheet for them to be easy to follow, to ask if this is GI problem, intake, if they have any, they are elderly, they are at risk of malignancy, what to do. Then, if he believes this patient elderly, he needs to do suggested from the history, he look cachexia, his underlying malignancy, he can proceed and do the initial investigation. If he believes this anemia, after he evaluate the CBC and he saw there is pancytopenia, hemoglobin is 6, I need hematologist, then there is a guidance what to do and to refer. The same thing for GI, if he's heavy smoker and he has lung sputum or blood, then he need to see pulmonologist, we guide him. Otherwise, he will follow the treatment to make it easy for them. We said we will make it the order sheet to have the treatment, the dose, the medications, and how to follow up. And the recommendation, our recommendation for IV iron, which one? If we put all the available in Saudi Arabia, and the institution, whatever available, he need to follow up these recommendations. In case if he has anemia for chronic illness, what the general GB has to do it, they need to investigate it. If everything corrected the iron, still the patient's showing anemia with low MCV, MCH, we suggested he need to be tested for hemoglobin increase, maybe he is having a trait. And there will be general information for supplement, and how to manage side effects. Here in the end of the protocol, there will be for iron, IV iron medication, and what to consider, what to inform the patient, and the side effect when he discuss. Majority of our patients, they will ask how frequent I have side effect. I know my colleagues, my relative, he had IV iron, he has this side effect. We need to be aware. The last paragraph was to show patient if iron deficiency, if they need, hemoglobin is low and symptomatic, when to give a blood transfusion. And here, so we will not lose the patient during treatment, is not one time treatment. Follow-up the patient is very important, and also the prevention, and when to consider to the hematology clinic, because we don't want to lose those patients, especially elderly. They are at risk of myelofibrosis, MDS, other bone marrow disorder. We suggest for them, if this is happening with the investigation, please refer to the hematologist. And in the second page will be 3 recommendations for IV iron and the side effect of these and how to monitor the patient when they're receiving IV iron. And how to manage, which is most important, hypersensitivity reaction in this patient. And this is the end of our first protocol. The second protocol is very important, is the childbearing woman. It is 15 to 49. This is non-pregnant lady and non-postpartum. It is mainly for a woman who is not pregnant. For a pregnant lady, they have different protocol. WHO recommended that the largest cause of dietary iron deficiency in those ladies, it's mainly iron and thalassemia and sickle cell trait and malaria. But we can see the estimated age of pregnant women is 37 and 30%. In some reference, they estimated 40% of childbearing, they are anemic. So we said we're going to focus again on our protocol. Our protocol is aimed to provide a standardized approach to screening, diagnosis, treatment, and follow-up of anemia in this group. And we did the same. We are targeting non-pregnant, asymptomatic, and women-specific risk factors. And here we define the hemoglobin in this age of population. And the same, they request the initial investigation. And to diagnose as iron deficiency anemia in a woman, the most common cause in this age is menstrual cycle. And to help the GB to understand, because a subjective history will be taken from the patient, the last column, we suggested for them to more questions regarding heavy menstrual cycle. What do we mean? And they need to ask about this. Because some lady, they have really heavy menstrual cycle and they think it's normal. It's just her mom's the same, her aunt's the same, so she thinks it is the same. But we as a clinician, we need to dig more about the menstrual cycle, how heavy is it? And from there we will go, if they have heavy menstrual cycle, what to do, because very important, we rule in such age, we rule out if they have any other bleeding disorder. And the treatment plan, we did the same. If it's confirmed and patient symptomatic, she hemoglobin 7, she might be candidate for IV iron. If they can, hemoglobin is low but asymptomatic or mild symptomatic, and you treat her with oral, you can do that. And the same thing, we did pre-check history for those patients, and just to ask, not to miss, we have a good prevalence of celiac disease. So patients are not textbook, they will not come only iron deficiency for heavy menstrual cycle, they might have also celiac disease, they might have other causes. Nowadays we can see young girls, they are more the effective media, and then they are more doing gastric bypass, Ozempic, other medication to reduce the weight. So we have to check the history and include it in these in pre-order. Screening indication, not to exhaust the health sources. They have to do 1, 2, 3. If it's positive, then they will proceed for more invasive. And treatment plan will be the same for those patients. And this is the order sheet guidelines. It depends on the clinician. If you think it is to go over it with the patient, advise them with the iron supplement, tea and coffee, some food high in fats. So it will be for the patient and for the clinician. And if he believes IV medication is needed, then he will proceed with it. And the same thing, hypersensitivity reaction, what to do, and there is one page for it. The other thing is the blood transfusion, because maybe he will say it's hemoglobin 6, but there is nothing recommended about the blood transfusion. So he needs to assess the patient. If she is symptomatic severe, tachycardia, the blood loss is happening very quick, then there may be a rule for blood transfusion. And as well, they need to follow up those patients. See the response. If they are not responding for treatment, what parameter I need to follow up. It's all written here. And this is the same thing, IV medication for the patient and how to manage hypersensitivity reaction. So in conclusion, clinical protocol for iron deficiency in high-risk population is essential, at least to ensure early detection, prevent complication, and guide it timely, which is very important. And if we did it evidence-based, early detection and tailored treatment in high-risk group improve the outcome. And this is mainly the aim. It's not only a paper protocol. The project of anemia in high-risk population, it's extended more than a protocol. They are planning to implement it, follow up, and there will be virtual clinic for the anemia. It's more beyond than a protocol in a paper. At the end, I would like to thank Dr. Hatoun, Dr. Salha, Mrs. Noura for their help. They did marvelous job. Thank you.
Okay, just because of the time commitments, and actually there has been some switches to the agenda, I want to really thank David Roberts, who came from England, from Oxford, for accepting this to come and talk to us last minute. So we will do the lecture for David first, and then we'll move to the panel discussion before Friday prayers. And I think it's really an opportunity, since Dr. El-Jouhi from the blood banks is here, to have everyone in the panel discussion. So Professor David Roberts is studied biochemistry at Cambridge Medicine at Liverpool University. He trained in adult medicine and hematology before undertaking a doctorate PhD at Witherell Institute of Molecular Medicine at University of Oxford. His work on malaria biology led to a Wellcome Trust Senior Clinical Fellowship and a Howard Hughes International Fellowship. He subsequently established a research group in the blood services in Oxford. He studied erythropoiesis and undertook large-scale trial in blood donors before becoming a medical director of the blood services. He was the clinical lead for convalescent plasma during COVID, and is now medical director for pathology and the clinical lead for the genomics program. Can we have Dr. Robert's slides up, please? I'm sorry for giving you the surprise, Ms. Malish. Presentation, Dr. David Roberts, yes. Yeah, so he will do his talk about genomics and pathology, improving patient and donor outcomes. David.
Thank you, Hatun, both for the invitation and that very kind introduction. It's absolutely wonderful to be here to hear so many inspiring speakers. I've already spoken to many of you outside the formal sessions and hear of the wonderful work that's been going on. So I'm going to tell you a bit about genomics and how we're applying it in the blood service. I'm just going to go quickly to explain some of our clinical problems, explain how we're applying genomics and applying it to genotyping of patients and donors. I'm going to stray slightly off topic but tell you something which I hope you can all use when you go back to your laboratories about the Duffy blood group and neutropenia, and then summarize. Well, it's a clinical conference, and I think it's appropriate to start with a case to illustrate the difficulties that I'm sure many of you know about when you look after your patients with sickle cell anemia. This is one of our patients, and we have perhaps 100 of people like this, people who have developed multiple antibodies to red cell antigens during their treatment, and as a result we find it very difficult to transfuse them. You can see this poor lady has only one unit in stock and very few units that are frozen. So it's difficult and takes a long time to find blood for her. And of course her access to more complicated transfusion therapy is limited. So what's the problem here? Well, we know that we always match for ABO and D, and for our sickle patients we undertake more extensive matching. Really, in principle, we could match for a much wider variety of antigens and perhaps prevent alloimmunization altogether. And some theoretical studies have been undertaken in the Netherlands, and if you look over on the far side there, you can see that if we extend our matching to KID, Duffy, big S and little s, with relatively small stocks at each centre, we could really considerably reduce the risk of alloimmunization. Of course, even if there's small stocks at each centre, it might mean we have to phenotype or genotype perhaps a quarter to a half our patients, but nevertheless that's possible in principle. Matching in general is very much at the core of what we do in transfusion medicine, and we'd like to match, and we have to match, not just for red cell antigens, but also for platelet antigens and HLA in blood products, and also of course for stem cells. Well, if we're going to have a simple genotyping typing solution, we have to really turn to genomics. And since the wonderful paper of Watson and Crick with Adele Crick, Francis Crick's wife actually drew the cartoon, the image that we all recognize as the structure of DNA, scientists have been working to establish not just the size of the genome, how to sequence it, and the variation, but in transfusion science, we have established the relationship between phenotype and genotype for all the significant red cell and platelet antigens. And just to give you a simple example, of course for the KID blood group, which we've identified as the urea transporter, we've identified how a single amino acid change is encoded by a simple change in a single nucleotide polymorphism. That's perhaps the most simple relationship between phenotype and genotype. And of course it gives us the possibility to type not just by serology but instead by genotyping. This work in transfusion science has really given us the knowledge of all the blood group antigens in terms of their genetic, underlying genetic structure. And the work of our in immunogenetics has identified many tens of thousands of HLA antigens and their genetic structure. So in principle, we can use genotyping to determine not just blood group antigens, platelet antigens, but HLA antigens. And to bring this together, our colleagues in the blood service here in the United Kingdom, led by Willem Ouwehand, but also scientists from across the world, assembled all this information and developed it into a simple genotyping platform. There are many ways to genotype, and in broad terms there's sequencing or using array-based technology. I won't go into the technical details, but the array can genotype over 1 million variants, and this is a schematic diagram. The array itself is about the size of a mobile phone, and each array is actually just one of these small squares that you see. It's about the size of a fingernail. And we've put on that the obviously the erythrocyte variants, but also platelet and HLA variants, and some of the other interesting genetic characteristics that we may see in blood donors for hereditary hemochromatosis and determinants that determine red cell quality. Well, it's taken about 18 months to develop, not just to validate that platform, but to turn it into a practical application. And I think this is an important point. When scientists say they validated a method, they're happy if they get results in 95% of people and that there are no substantial errors. But if we are to use a test for clinical application, we really need a valid result in 100% for patients. And that's taken some time because about 5 to 10% of the test results need more complex analysis. And as you might guess, that is to determine the underlying rhesus blood group and the MNS blood group, where they're complex gene duplication and hybrid genes. But we've been able to do that and turn it into a practical tool. So how should we apply this? Well, we're very fortunate that the Department of Health prioritized the genotyping of the sickle cell patient cohort. We have a cohort of sickle cell patients that's about a fifth the size of the cohort in Saudi Arabia. We have 20,000 patients, and we asked doctors and clinics to send those samples into us. And you can imagine that's not always easy to get doctors to tell you what you want them to do. But over half, we've got samples on over half the patients and are well on our way to genotyping that whole cohort now. We have established a multidisciplinary team to discuss the difficult cases, and we have now being able to issue results for many thousands of patients. Now, our cohort has been phenotyped extensively, and many of them have also had genotypes. So perhaps just to look at the most significant results, I think if you were genotyping a cohort for the first time, these figures would be slightly higher. But the most significant immediate results for patients are to find those patients who have, partial RHD types, because they should receive RHD negative blood and not RHD positive blood. And similarly, patients with partial C types should receive RHC negative blood. And I think you might expect those in an ungenotyped cohort, perhaps those to be 5 to 10% of patients. Well, we want to ultimately use these results to provide much better matched blood for our patients. And to do that, we have to type our donor population. And we're very fortunate in in England and the United Kingdom that we established during many of the trials we did co-enrollment in clinical trials, but also in biobank studies. And over 100,000 of our patient donors were enrolled in biobanks and genotyped. And we've been able to use those results to pick out the most valuable donors, those donors who have rare blood groups, but also donors who are homozygous for the clinically significant antigens, and we're retyping those. So we're going to continue that work, and in a second phase of typing, we're going to genotype 10 to 20,000 of donors of African descent, and that group, of course, it's particularly valuable to type the variant RH groups and those blood group antigens which we can't type by serology. Although if we have a big stock of typed units and our typed patients, it's not a trivial problem to work out which blood to give to which patient. If you're finding blood for one patient, you can search for one genotype. But if you have tens of patients to type at in one day with thousands of units in stock, we need an algorithm, a machine learning driven algorithm, which will mathematically select the best matches for the whole cohort to maximize the best use of that. And it uses the mathematics of linear programming and transport mathematics, which people use to allocate resources in all sorts of ways. So we're doing an initial study in 40 patients at University College Hospital, and we hope to roll that out to 40 hospitals. And as many of you who work with complex systems will realize that although the science is relatively straightforward here, integrating systems, having data transfer, and ensuring patient safety is really operationally the most difficult part of this study. Well, ultimately, our vision then is to have a genotype-driven blood supply system for our most difficult to match patients, where we will genotype our donors, our patients, have a appropriate and efficient matching system, and then supply genotype blood to patients. I think one of the other corollaries of phenotyping or genotyping donors is they become more valuable to you. We would want them to return, we would look after them carefully and call them in when we need specific genotyped units. Well, I've mentioned this array can provide blood types for all blood products. And so if you start to genotype your population in this way, your donor population, you can really use it to replace screening for rare platelet types, for HLA types, and we are starting a program which I don't have time to speak about today, where we provide HLA selected red cells and platelets to renal transplant and waitlist patients to prevent immunization. We also in the United Kingdom have relatively high prevalence of a mutation that causes high potassium leak from red cells, and we can identify those donors and eliminate those donors from giving blood to neonates. And we have one high frequency monogenic disease in the UK, hemochromatosis, and when we genotype the donor population, we can identify and counsel donors appropriately. So that's in a nutshell the program that we've got. But I would like to just turn briefly, if I may, to a clinical problem which I think is relevant to all the hematologists here, and that's the problem of neutropenia or low white cell counts. In the United Kingdom, we have a reference range from about 2,000 to 7,000, but we know that certain ethnic groups, if I may use that term, have a tendency to have lower neutrophil counts. I think we take it into account sometimes, but rarely do it, in fact I would say never really do it in a systematic way. And we've understood that there are many genetic characteristics that are associated with the neutrophil count, but it turns out the main driver for them is really the Duffy antigen, which is a receptor for the IL-8 chemokine. We thought it might be very complex to define patients who have a genetically determined low neutrophil count, but it turns out to be much easier than we anticipated, because if we do a survey, we've now been able to do a survey of blood donors from different parts of the world who are just negative for the Duffy A and B antigens, and these are the results here. You can see immediately in the UK population that about 20% of those Duffy A negative, B negative donors actually have a neutrophil count in well-fit, healthy donors below our reference range. And the same is true in a Saudi population. These donors and patients were actually from Jazan, and it's true in other situations, in other populations across the world. So you can see immediately when you look at the association between the Duffy negative, A negative, B negative phenotype and neutropenia, neutrophil counts, an absolutely, I won't say perfect, but a very, very close correlation. You can see in different populations, not just the African population, but in population in the Eastern Mediterranean like you have here, that only those patients with Duffy A negative, B negative have a normal neutrophil count below our UK reference range. So we can use that to, I think, have different reference ranges now for the Duffy A negative, B negative people, and a different reference range for other people. And I think this will be useful not just for investigation of patients who appear with a low neutrophil count, but perhaps significantly to understand and devise new criteria for entry for clinical trials, because I think people who have low neutrophils are being underrepresented in trials, and I think they're probably being undertreated for many, using many drugs where the neutrophil count is important to determine the dose. Of course, cancer therapy, olazapine, which is used in a very important drug for control of schizophrenia, but also relevant here is hydroxyurea. And I think we yet have to determine what are safe neutrophil counts for those who have a genetically determined low neutrophil count. So this conference obviously has a great interest in transfusion medicine, and I'm not able not to talk, I can't really go into the principles of our blood service in the UK, but I know you're developing very quickly similar services which have all these integrated functions which are important to develop and deliver safe transfusion therapy. And of those, I would really just pick out the high levels of repeat donation, and as Hatoun is developing a national databases for patients and their clinical outcomes. So I'll just close then, and obviously I've explained how we're beginning to develop large-scale genotyping, how it needs expertise in not just serology, but now in bioinformatics and genetics, and I think that's something that all blood services will develop, and bring in expertise from the scientific community to help you to deliver those services. I think there's a real prospect of delivering better matched products for our patients, not just through genotyping, but much more extensive serotyping of our donors. And I've mentioned some of the other exciting possibilities that genotyping will give in transfusion medicine and hematology. So I've really given you a short tour of what we're doing. I hope that excites you, and I'm sure there'll be many interesting discussions. And no presentation is complete without acknowledgements. And when you're presenting a large program like this, Of course, they're not just a few individuals to thank, but whole teams of people, led now by Kate Downs. But it really is beginning to touch all aspects of our transfusion service, both in the scientific departments and the operational departments. And I won't go through them all, but you can see there the breadth of the work that we're doing. Thank you very much.
Thank you, David. This is great, absolutely, and thank you for just answering our call last minute. I'd like to invite all speakers and moderators of previous session for the panel discussion.
We'll have one أسفل مع أحد. خلي واحد أسفل. You start to sing and sing.
Any questions from the audience or from the panel? Dr. Saud?
If you allow me, I have actually one question for each speaker. The first question is for the last speaker, Professor Robert. What is the impact of doing this genetic typing in the cost of each unit of blood? And this is accepted by, is it accepted by the authorities that they are going to sponsor doing the genetic typing?
So we will genotype the donors. I think one thing I should explain is that we probably have to genotype or serotype them twice. So it's really when they come to give blood the third time that we're able to issue these extended typed units. And in terms of acceptability, we're really limiting the results at the moment just to blood group types and to HLA types. So the acceptability is really covered by our existing consent to type donors to provide better match products. We're only going to return other results to them, as I mentioned, under specific protocols, research protocols. In terms of the array, it's now approved under exceptional use authorization and is not yet a CE marked product, but we will be giving it our own internal quality assurance because we can do that as a blood service. We can provide internal validation for the array. But other solutions are becoming available. We haven't done comparative studies, but I think they all will have similar problems of that. Although they will be valid for 95% of types quite quickly, I think resolving the remaining 5% of queries will take particular care and expertise. I hope that answers the question.
So the impact in the cost of each unit, let us say that 1 unit of backed blood cells, serology type, only it costs £1,000, and so if you are doing molecular or genetic typing for that unit, What will be the cost? Double, 3, 10 times?
Right. Well, the cost of typing a donor would be about between $75 and $150, depending on the method. At the moment, we're not applying extra costs for typed units. For the HLA match red cells, we apply a nominal cost of $200 or $300. But to apply the genotyping program across, for each donor would be about $100 per or $200 per donor. So the cost per unit would be depend on how many times that donor gave blood.
I think this cost actually is very well accepted, especially if you are doing very precise cross-matching. $100 is acceptable actually, rather than you are facing all the side effects.
Second question?
Yeah, second question to Dr. Ferja. Congratulations for this work. It's really very interesting and easy to do. And not only that, the outcome that you are including the BAP smear and the stool occult blood, so you are preventing more serious complication and treating simple disease with simple intervention, which has excellent impact. Just my question actually, almost every day I'm facing patients, especially the fashion nowadays, everybody is doing bariatric surgery, and they are ended by anemias, all type of anemias, include iron deficiency anemia, and unfortunately our surgical colleague, they don't warn their patient, and you ended by one patient with hemoglobin of 4 or 5 after a few years or months of from the bariatric surgery. So it's really very interesting, and I hope that everybody will apply it.
Thank you for your comment. Yeah, I totally agree. This is a project which I salute Dr. Hatoun to be the headmaster and to think about this project 2 years ago. And we had the same questions with Dr. Inshirah, just we chatted about now with very common, we see bariatric surgery, and it's a chronic problem. Those after the surgery, they just come back for IV iron, for medication. Shall we, who should see them, a hematologist or GB or family medicine? What's the plan? The aim of the protocol is not treatment only. The aim of a protocol to have a healthy individual and not to miss other diagnoses. Some of the patients, those who had gastric sleeve especially, they might have ulcer later on, they change the gastric pH and affect their absorption. Need to be ruled out, these causes. According to the literature, if any patient did gastric sleeve, they should have normal absorption for iron after 6 to 1 year. 6 months to 1 year should be normal. But if you notice, our population is not. They just have a frequent, it's like lifelong problem for them with IV iron. But I think those patients, if they have persist, they need to be further evaluated. Their GI is normal. It could be have the problem of iron. It was there before the gastric sleeve, aggravated by gastric sleeve. This is why it need to be noticed. But the aim of a protocol for those patients, even not to miss other diagnoses for them. This is why we suggested and to patient for family medicine or GB or who's seeing this patient in the first hand need to keep in mind all these possibilities, and we put in the protocol when to see them again. If the problem is persist, then you have to seek a help for those patients. And Dr. Hatoun, even because she is implementing the protocol, and there is follow-up for those patients, and she can give us.
Yeah, I just want to take the opportunity. First of all, I want to thank Prof. Farja for working with us for many months on this, as well as my team. So right now we have finalized all the work, and we came up with what she showed. We have submitted a paper for publication too. But this program is dedicated, I know it sounds like bread and butter for hematologists and for hematologists listening to us on the YouTube channel as well, but I'm pretty sure as much as it is an area of pain for me as a hematologist, it is an area of pain for all of us as hematologists. The protocol and the program is intended for primary health care providers. Since now the transformation had established a physician for every family or a family physician through صحتي. So this is applied through صحتي, where physicians will see those patients, apply the protocol, and then we could have a seamless transition or transfer process to hematologists in MOH and outside of MOH. The other thing, we're running an awareness and education campaign parallel to that as well for GPs, for public to come forward, because most of those patients will not come forward unless they're really symptomatic, which is really at a severe stage. The last thing, the program, we've expanded to rejected donors from blood banks as well. So those patients, we have an agreement with the blood banking system that they will refer those patients to us. So based on this, we are starting an iron deficiency anemia clinic at the Sahha Virtual Hospital for those patients. Thank you so much.
May I recommend also to include the private sector? Because
yeah,
this is
of course.
most of the disaster is there.
Yes, of course, of course. I think the disaster is more there. Do you have any طيب ناخذ دكتورة أروى ونرجع لك. دكتورة أروى.
Good morning. Thank you very much. Very excellent session with interesting presentations. Just also to comment about this program that you have successfully developed, it will be very helpful for patient blood management, especially for patients who are undergoing plans for surgeries. And having that foundation would help you also to minimize transfusions in this group of patients. I have a question to Professor David Roberts. Very interesting presentation. Thank you for sharing your experience. We have published data among Omanis to show that the rates of Duffy A and B negativity is almost 70%. And we did confirm that the common mutation in the promoter region of the GATA is the responsible mutation to explain the GATA, the Duffy A and B negativity. I was just wondering about the chemokine mutation that you listed, linking neutropenia with Duffy A and B negativity. Have you looked into the relationship of that with GATA mutation, considering its predominance in Duffy A and B negative donors and individuals?
Yes, it is certainly associated with the GATA mutation. I think the importance of this study, which is a very simple study, is that instead of genotyping these patients, we can just do the Duffy A negative, the Duffy A and B serology. You know, if they're Duffy A negative, B negative, the reference range for the neutrophil count would be lower. So I think that really makes this applicable to every laboratory, because instead of genotyping someone who comes with low neutrophil count, we just need to run the serology, which you can do in half an hour. So the British Society of Haematology are going to develop guidelines. So I mean, I hope soon those will be published. But I think laboratories will be able to use simple serology to use neutrophil reference ranges.
Unfortunately, I will not be able to take any more questions just for the sake of the prayers, but the discussion continues and we're around to answer any questions and network further. The buses to transfer to the mosque are outside at the lobby, the main entrance. Lunch will be at 1 p.m., second floor, Mazaj restaurant. And then please be back sharp at 2 for the opening ceremony. But I'd like to ask something. Please do not leave any belongings in this room, because we have to reorganize the hall for the opening ceremony. Thank you so much, and see you at 2. Or see you at 1 for lunch. Thank you.
الله check 1 2 3 check 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 1 2 3 test بسم الله check هي تسم هي.
خلاص جهزت التكريم سلايد كذا بس هذه صورة تكريم بقول لك متى أيوه
بسم الله الرحمن الرحيم.
السلام الملكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين المتفرد بالكمال المتعالي عن النقص والامتهان، والصلاة والسلام الأتمان الأكملان على سيدنا محمد خاتم النبيين وإمام المرسلين. أصحاب السعادة، الضيوف الكرام، الحضور الأفاضل، السلام عليكم ورحمة الله وبركاته. تعزيزاً لمنظومة الرعاية الصحية وتأكيداً لالتزام المملكة العربية السعودية بدورها الريادي في دعم الصحة وبناء مستقبل صحي أكثر أماناً وجودة للإنسان، ترحب المملكة بالعالم في القمة العالمية الرابعة لأمراض الدم الوراثية، وذلك تحت رعاية كريمة من معالي وزير الصحة الأستاذ فهد بن عبد الرحمن الجلاجل، وبحضور سعادة مساعد وزير الصحة للخدمات الصحية الدكتور محمد عبد العالي نيابة عن معاليه. ويأتي انعقاد هذه القمة امتداداً لما توليه حكومة خادم الحرمين الشريفين الملك سلمان بن عبد العزيز وسمو ولي عهده الأمين رئيس مجلس الوزراء الأمير محمد بن سلمان حفظهم الله من رعاية كريمة للقطاع الصحي واهتمام راسخ بصحة الإنسان ودعم متواصل لتطوير منظومة الرعاية الصحية. أيها الحفل الكريم، خير ما نبدأ به آيات من الذكر الحكيم.
بسم الله الرحمن الرحيم.
نون والقلم وما يسطرون، ما أنت بنعمة ربك بمجنون، وإن لك لأجرا غير ممنون، وإنك لعلى خلق عظيم.
صدق الله العظيم. خلف كل عمل بصمة، وخلف كل إنجاز رؤية، وخير من يروي قصة البدايات هو صاحب البذرة التي نرى ثمارها اليوم. يسرنا أن نستمع وإياكم اليوم إلى كلمة المشرف العام على إدارة خدمات أمراض الدم بوزارة الصحة الدكتورة هتون عزت.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. صاحب المعالي وزير الصحة الأستاذ الدكتور فهد بن عبد الرحمن الجلاجل حفظه الله، سعادة مساعد وزير الصحة للخدمات الصحية الدكتور محمد بن خالد العبد العالي حفظه الله، أصحاب السعادة، شركاء النجاح، ضيوفنا الكرام، السلام عليكم ورحمة الله وبركاته. اليوم لا نفتتح مجرد مؤتمر عالمي، بل نفتتح قصة وطن آمن بأن صحة الإنسان هي أعظم استثمار وأسمى مسؤولية وأعمق رسالة. نلتقي في القمة الرابعة للابتكار في أمراض الدم الوراثية، ونحن نحمل إيماناً راسخاً بأن خلف كل رقم في التقارير حكاية إنسان، وخلف كل بروتوكول علاجي حلم حياة أكثر جودة، وخلف كل مشروع وطني قلب وطن لا يرضى إلا أن يكون الإنسان فيه أولاً. إن رعاية معالي وزير الصحة وتشريف سعادة المساعد الدكتور محمد العبد العالي لهذه القمة ليست مجرد دعم لفعالية علمية، بل رسالة وطنية تؤكد أن المملكة العربية السعودية بقيادتها الرشيدة جعلت صحة المواطن والمقيم في صميم رؤيتها التنموية ضمن مسيرة رؤية المملكة 2030 التي نقلت الطموح إلى واقع والإنجاز إلى ثقافة عمل. لقد شهدت المملكة خلال السنوات الماضية نقلة نوعية في رعاية مرضى أمراض الدم الوراثية، بدءاً من برامج الوقاية والفحص المبكر، مروراً بتطوير الخدمات التخصصية ومراكز التميز، ووصولاً إلى تبني أحدث العلاجات المتقدمة والعلاجات الجينية التي أعادت الأمل لمرضى كانوا ينتظرون الشفاء. كما نفخر بأن هذه المسيرة الوطنية تمتد بشراكات عالمية راسخة مع جهات دولية مرجعية، وعلى رأسها الورد فيدريشن اوف هيموفيليا والثلاسيميا انترناشونال فيدريشن، واللتان تمثلان نموذجاً عالمياً في دعم المرضى وتعزيز البحث العلمي وتطوير معايير الرعاية، مما يعكس مكانة المملكة كشريك فاعل في الجهود الدولية للارتقاء بصحة الإنسان. لكن ما يجعل رحلتنا مختلفة وهو أننا لم ننظر إلى المريض كحالة طبية فقط، بل كإنسان له أحلام وله أسرة وله مستقبل يستحق أن يصان. ومن هنا جاءت المبادرات الوطنية التي تعزز جودة الحياة وتدعم الصحة النفسية والتغذوية والنشاط البدني وتمكين المرضى ليكونوا شركاء في رحلة العلاج، لأننا لا نؤمن أن الرعاية الحقيقية تبدأ عندما نحتضن الإنسان بكل أبعاده. ولا يفوتنا في هذا المقام أن نعبر عن خالص التقدير والامتنان لجمعيات المرضى وشركائنا من المجموعات الداعمة للمرضى الذين كانوا ولا يزالون صوت المريض الحقيقي، وشركاء أصيلين في مسيرة التطوير والتمكين والتوعية المجتمعية. لقد أثبتت هذه الجمعيات أن العمل الإنساني التطوعي قادر على صناعة الأمل وبناء الجسور بين المرضى وذويهم ومقدمي الرعاية الصحية، وتعزيز ثقافة الشراكة التي تضع المريض في قلب منظومة الرعاية الصحية. هذه القمة تمثل منصة وطنية وعالمية تجمع العقول والخبرات وصناع القرار لنرسم معاً ونضع البصمة لملامح مستقبل تتكامل فيه الابتكارات الطبية مع القيم الإنسانية، وتتجدد فيه الجهود بإذن الله البحثية مع المسؤولية المجتمعية لنصنع نموذجاً سعودياً يحتذى به عالمياً في رعاية أمراض الدم الوراثية. إن ما تحقق لم يكن ليرى النور لولا توفيق الله عز وجل أولاً، ثم دعم قيادتنا الحكيمة وجهود فريق العمل المختص الذي آمن أن العمل الصغير عندما يصنع بإخلاص يصنع أثراً كبيراً في حياة الإنسان. وفي هذا اليوم نجدد العهد أن تبقى المملكة منارة للعلم وموطناً للإنسانية ونموذجاً عالمياً في الابتكار الصحي، ونسأل الله أن تكون هذه القمة محطة جديدة نكتب فيها فصلاً مشرفاً من قصة وطن جعل من صحة الإنسان قضية حياة. والسلام عليكم ورحمة الله وبركاته. اليوم وبكل فخر انتهز هذه الفرصة لنشر وتدشين الدليل الوطني للرعاية بأمراض الدم أمراض الدم الوراثية وتحديداً الثلاسيميا أو أنيميا البحر الأبيض المتوسط. تشرفنا بالعمل على مدار السنتين الماضية مع نخبة من الأطباء السعوديين والمختصين لإنشاء هذا الدليل ليكون المرجع الأساسي للمملكة العربية السعودية ومثال يحتذى به بإذن الله عالمياً. تشرفنا كذلك بمراجعة الدليل وتنقيحه من قبل Thalassemia International Federation. I'm happy to announce today that we're publishing the first consensus statement for the care of patients of thalassemia in Saudi Arabia, written, reviewed, edited by Saudi experts, and forwarded, endorsed by the Thalassemia International Federation. I would like to ask Dimitris, please, to come and endorse the consensus. Thank you.
Thank you very much. It's a great honor for me to represent the Thalassemia International Federation in this very important conference. Let me first start by expressing our gratitude as the Thalassemia International Federation for being part of this important initiative. I also wish to convey the warm greetings and the best wishes of TIF's president, Mr. Panos Eglesios, TIF's executive officer, Dr. Androu Eleftheriou, who were unable to be here in person, but their support and interest are very much among us here today. This is a very important conference of high caliber, and this high caliber of the conference reflects actually the tremendous progress that the kingdom is making in the management of patients with hemoglobinopathies. And this concerns not just access to high quality standard of care, but also access to curative and innovative therapies. And of course, TIF is very proud and delighted to be part of these efforts in the service of our patients. So we are really, and we express our gratitude to you for your ongoing dedication and commitment to the management of patients with thalassemia at this very high and innovative level. So just a few words about this document, which is the consensus statement for the management of patients with thalassemia. The scope of this document was actually to develop and implement a set of national guideline recommendations for the management of patients with thalassemia, and through this to promote high quality care in accordance to the international standards, and at the same time strengthen the harmonization and standardization of care provision across the country, which is actually a very important issue. This is the task force. It was headed by Professor Hatoun Ezat, written and reviewed by experts on hemoglobinopathies across the kingdom, and with the contribution of Thalassemia International Federation experts. This is the table of contents, starting with an introduction covering briefly the epidemiology and burden of thalassemia, then the genetics and the pathophysiology of the disease, then the screening programs that are in place for patients for thalassemia across the kingdom, both including both premarital and newborn screening, then the different components of care, and also including multidisciplinary care, which is very, very important, but also the transition from the childhood to the adulthood care, another very important issue, and of course aspects related to quality of care. Then two chapters, one on transfusion-dependent thalassemia and another on non-transfusion-dependent thalassemia, covering the different complications and the multidisciplinary management of the disease. And then of course a chapter, very important one, for the telemedicine services that are in place for patients with thalassemia across the kingdom. And of course this is just one initiative out of a big program of innovation for the management of patients with thalassemia and hemoglobinopathies that includes projects like the MOJA project, including a national registry, screening programs, vaccination programs, programs for access to multidisciplinary care, and of course access to curative therapies, including bone marrow transplantation and gene therapy, and access to innovative medications. This is the first country where mitapivat, innovative treatment, was actually approved for the management of thalassemia, and of course the consensus document. And with this, I thank you very much for the kind invitation. I congratulate for this tremendous progress and efforts. Thank you very much.
Thank you, Dimitris. Just actually a final word. Everyone in this room who's Saudi and non-Saudi and had lived in this giving country wants to give back. And no matter what we do, we will never be able to give back all. So we decided, since the Saudi founding day is in 2 weeks and it will be Ramadan, so it will be hard to celebrate, that one of the things that we're giving back to this giving country is the Saudi consensus. So the Saudi consensus will be available to everyone on the Saudi founding day, inshallah, on the February 22nd. So the other second important part, we're signing today two very, very important MOU for the Blood Disorders Administration and for the Ministry of Health. And we're very happy and I'm privileged and honored to sign the first MOU with the Thalassemia International Federation. I call upon Dr. Abdel Ali to come to the stage, please.
والآن مع توقيع الاتفاقيات فليتفضل سعادة مساعد وزير الصحة للخدمات الصحية الدكتور محمد عبد العالي بالصعود إلى المنصة. مذكرة تفاهم بين وزارة الصحة ممثلة بإدارة خدمات أمراض الدم والاتحاد الدولي للثلاسيميا. مذكرة تفاهم بين وزارة الصحة ممثلة بإدارة خدمات أمراض الدم والاتحاد العالمي للهيموفيليا. أيها الحفل الكريم، يسرنا أن نعرب عن تقديرنا لشركاء النجاح في القمة العالمية الرابعة لأمراض الدم الوراثية، وندعو السادة المتحدثين ومدراء الحوار ورؤساء الجمعيات للتفضل بالصعود إلى المنصة لالتقاط صورة جماعية مع راعي الحفل. أيها الحفل الكريم، وفي الختام نتقدم بخالص الشكر والتقدير لشخصكم الكريم على تلبية الدعوة ومساهمتكم الفعالة في هذا الحدث. كما نتوجه بخالص الشكر والامتنان إلى راعي الحفل، وندعوكم الآن بالتفضل إلى الانطلاق في الجولة التعريفية للاطلاع على أبرز فعاليات ومبادرات القمة.